Welcome to Senadipin Education Foundation once again. Gaining knowledge is the first step to wisdom. Sharing it is the first step to humanity. We started this educational program way back in 2007 by releasing a brochure from our institute. It was released by Professor Antonio Longo from Italy. The Senadipin Education Foundation was launched in 2012 Jan by Professor JIGNESH, a colorectal surgeon from Korea. We had free fellowship programs of 6 months and 1 year with hands-on in both basic and advanced laparoscopy surgery since then. We give hands-on training to the candidates. With the advent of COVID, we started the online programs, and our logo was released online by Professor Palanivelu from India. Then we started having online live surgeries in Facebook Live and YouTube Live. The first Facebook Live was Lab LAR, and YouTube Live was Lab Whipples, which was completed in 100 minutes. The link was shared to the members of Senadipin Education Foundation. Then we started having live lectures with world leaders like Professor Yohann Renard. Recently, we started international fellowship programs in lab SBB surgery, lab colorectal surgery, lab upper GI surgery in Japan, France, and Korea. These are the candidates who recently finished their fellowship program with Professor Nagakawa Yuchi at Tokyo Medical University. Now, for the next program, we received almost 418 applications from 68 countries for the next batch. Now, Senadipin Education Foundation is having presence and representation all over the countries. These are the ambassadors of Senadipin Education Foundation. We have ambassadors in more than 35 countries. In the season 1, we had 28 webinars with world leaders. This is one of the taught by ERA Society. Our chairman, Professor Ali Linkis, gave a wonderful ERA talk at the recent Senadipin Education Foundation, one of the largest online meetings with over 1,400 delegates from 72 different countries. We have appearance in social media. This is Senadipin Education Foundation WhatsApp groups. We have about 3,250 members in the WhatsApp groups. And this is our Facebook group and YouTube channel. All the webinar videos are available in the YouTube channel of Senadipin Education Foundation. Today we have an eminent leader in hernia surgery. He is not only an anatomist, he is a surgeon par excellence. He is from France. He is the head of the Department of Surgery and Anatomy, University of Hospital, Reims, France. Is none other than Professor Yohann Renard. He will be officially introduced by one of my colleagues, and it will be moderated by Professor JIGNESH Gandhi, a leader in the hernia surgery field in India. Dr. Abdullahi from Kenya, who is my colleague now, will be introducing the moderator and the speaker. Before that, let me invite all of you to the next webinar that is going to happen on 22nd of January on pancreatic endotherapy by Dr. Rajesh Puri. Before handing over the mic to Dr. Abdullahi, I request all the participants to mute their mic on entry. If possible, kindly acknowledge by renaming your device by yours. The participants logging from outside India are requested to reveal their identity in the chat box. Raise your hand if you want to intervene in between the talk. Everybody will be given permission to unmute their mic if they want to speak. If you are on a portable device, please mute your audio and hide your video. If for any queries regarding fellowship programs, international fellowship or offline programs, just write to me, senadipan@gmail.com. Thank you all. Welcome all of you once again to Senadipan Education Foundation. I request Dr. Abdullahi to formally introduce the moderator and the speaker.
Okay, thank you so much. Welcome everyone. Welcome everybody to Senadipan Education Foundation. And thank you, Professor Baiju Senadipan, for giving me this opportunity to introduce our speakers today. We have two impressive gentlemen who are at the top of their respective fields, Professor JIGNESH Gandhi and Professor Dr. Yohann Renard. They will take us through the surgical anatomy of the groin. As we know, anatomy is the foundation of any surgical procedure. Inguinal anatomy is becoming a revolution thanks to laparoscopy, as we find potential spaces and orifices which were initially unexplored in the regular cadaveric dissections. Learning anatomy has been from outside in, but with the advent of laparoscopy and magnification, now we learn anatomy also from inside out. Without further delay, I will introduce our moderator for today, Professor JIGNESH Gandhi. He is a general and laparoscopic surgeon. He is the professor of surgery and unit head at King Edward's Memorial Hospital in Mumbai. He is consultant at BARC Hospital in Mumbai. He did his MBBS and his MS in general surgery at Shivaji University in Kolhapur. He is also a board certified surgeon. He did his fellowship in clinical research at King Edward's Memorial Hospital. He is a member of several associations, among them Association of Minimal Access Surgeons of India, Indian Association of Gastrointestinal Endosurgeons. He has more than 24 publications with numerous citations. He has written and presented several articles in national and international conferences. And he has won multiple awards all through his career. And he has co-authored a book entitled Hernia, What Can We Do About It? These are some of his recently published articles. And these are some of the clinical trials Professor JIGNESH Gandhi has participated in. On to our speaker for today, Professor Dr. Yohann Renard. He is a professor of anatomy at the University of Reims in France, and is also hernia surgeon at Reims University Hospital. He received his university degree in pedagogy at the University of Reims. He received his university degree in laparoscopic anatomy at the University of Marseille-La-Timon. He got his specialized degree in digestive surgery and hepatobiliary surgery at the University of Paris-Sud. He worked as a general and digestive surgery resident at Reims University Hospital. From 2019, after he got his PhD, he became an associate professor at Reims University. He did his PhD at the Doctoral School of the University of Lorraine, and his research topic was on pancreatic segmentation. He has participated in several clinical research work, among them the Symbios trial on biological meshes. He has more than 50 publications with more than 500 citations. He's a board member of the EHS, and he has contributed to the EHS guidelines, is a member of the French Association of Surgery, and is the president of the French National Association of Young Visceral Surgeons. These are some of his publications. Thank you so much. Over to you, professors, for the discussion for today. Thank you.
Dr. Jignesh Gandhi, now your turn.
Good evening, everybody, and first of all, greetings of the new year to all of you across all the continents. It's my pleasure to have my dear friend Yohann to give us a talk today on surgical anatomy of the groin. And thanks to Dr. Baiju, who has been running this program so successfully ever since COVID. And we've got class speakers across the globe who are educating all of us. And I can understand the zeal and the enthusiasm that on a Sunday evening, we have at least about more than 600 people online, sparing the time out of their family to hear to your talk. So without further delay, I would present Professor Yohann, and at the end of it, we will have some question, answers, and moderation. Thank you so much. Over to you, Professor Yohann.
Thank you. Thank you very much for a nice introduction, and wish you all participants Happy New Year, and hope you will enjoy these new drawings about the anatomy of the groin.
So for Yohann, I will be playing this video.
Perfect. We will first draw a small introduction of this groin area anatomy. It is an anterior view of a right groin with the coxal bone, the pubis, just here, the pubic tubercle, and the obturator foramen. This area is located in the inferior and lateral part of the abdomen. It is a pair, bilateral and symmetrical area. It is a transition area between the abdomen, the lower limb, and the genital organs. And now we can see the inguinal ligament. Very important, it is formed by the anterolateral muscles, and in particular with the external oblique muscle. Behind, we can see the psoas iliac muscle. This muscle is a posterior muscle. So this groin area is very complex because it is the convergent point between the posterior muscles, psoas iliac, and the anterolateral muscles shown by the inguinal ligament. In the middle, we will find the femoral . Where is the sound?
Dr. Baiju, can we, I think we'll need the volume.
It is mute.
Dr. Yohann, do you want to talk while this is going on? Is it okay?
Yes, yes, if you want.
Yeah.
If you want.
Yeah, please,
yes.
please go ahead. Please go ahead. Yeah, please go ahead.
Okay. Currently, we can see the groin area. It is a triangle shape, you know, between the umbilicus, the pubis, and the anterior and superior iliac spine. And this triangle is in the middle, in the transition area between the testicle, and it gives two running paths to the testicle, it is the inguinal canal, and to the thigh, it is the femoral canal. To the thigh, perfect. It is the femoral canal. This anatomy explains that this groin area is very complex. Why? It is concerned by highly frequent diseases due to these 2 points of weakness, inguinal hernia and femoral hernias. The knowledge of this anatomy is essential for surgeons to perform good repairs. We want to say some words about comparative anatomy, and we will compare the humans with the quadruped. It is a lateral view, and we can see the sacrum with the sacral vertebrae, the coxal bone with the anterior and superior iliac spine, and the obturator foramen just here. The quadruped have a large kyphosis with the lumbar vertebrae just here. We can draw the skin of the quadrupeds and the belly just here, and the lower limbs right here. So the quadrupeds have a very small angle in the groins, so it is very uncommon to develop groin hernias. During evolution, the humans stood up, the spine is now vertical with lordosis in the spine, and we can see here the belly, which is vertical right now in the humans, and the lower limb gone posteriorly like this. So in the humans, they have opened their groin area with a large angle, explaining the risk of groin hernias. If we draw here the inguinal ligament and the anterolateral muscles with here the conjoint tendon, we will find again the 2 channels with the femoral canal just here to the thigh and the inguinal canal just above, inguinal canal here to the genital organs. That explain the risk of groin hernias in the humans compared to the quadrupeds. The embryogenesis is very, very interesting, and we will draw an embryo. It is a lateral view. Here we can find the genital tubercle, the genital bedding, the future anal canal, and the back of the embryo until the umbilical cord forward. Here is the future pubis, and then the future urinary system with the future bladder. We will now draw the future peritoneum with the somatopleuric mesenchyme, the cul-de-sac of Douglas, and the splanchnopleuric mesenchyme with the future mesorectum. This future peritoneum is forming the intraembryonic coelomic cavity just here. Back we can find the mesoblast just here, and the genital crest just here. It is the future gonad. All these structures are in lumbar position. The future testicle is attached by the mesonephrotic duct or duct of Wolff. It is in an extraperitoneal position. Here we can find the inguinal ring and the peritoneovaginal canal. It is a connection between the coelomic cavity and the genital bedding. And now we can find the migration of the testicle until the scrotum using this peritoneovaginal canal. This migration is formed in an extraperitoneal position. One step later, we can find again the genital tubercle. It is the penis, the genital bedding. It is the scrotum with the anal canal. The pubis is just here, and just behind the bladder. Drawn in yellow, with the urethra just below, inside the genital tubercle. The mesonephrotic duct will give the vas deferent just here, using the peritoneogenital canal until the scrotum. And the testicle, as made its migration, is now in the scrotum and is covered by the epididymis just here. And the peritoneovaginal canal is closed, is forming the cloquet ligaments, and around the testicle is forming the tunica vaginalis. The bladder and the vas deferent are in an extraperitoneal position just here, with the mesorectum and the cul-de-sac of Douglas in the back. The inguinal canal is just here, and all the structures forming the inguinal canal are coming from the abdominal wall, explaining the risk of inguinal hernias. The first view is an anterior view with the anterior and superior iliac spine, acetabulum ilion, the pubic tubercle just here, and the obturator foramen. And we will see the hip joint with the femur right here, greater trochanter, lesser trochanter. And we are drawing now this iliopectineal eminence with the inguinal ligament and the iliopectineal ligament just here. This ligament limits laterally the muscular area or muscular lacuna, and interiorly the vessel area. Laterally, it is the psoasciliac muscle inserting on the lesser trochanter. Medially is the vascular lacuna with the femoral artery, femoral vein, just here. Interiorly, it is the femoral channel limited posteriorly by the pectineal ligament or ligament of Cooper. It is the pectineal muscle just here with this Cooper ligament. Medially, we can see the lacunar ligament of Jean-Bernard. Superiorly and anteriorly, the anterior muscles with the rectus abdominis muscle just here. It is cut in the level of the umbilicus just here. It inserts inferiorly on the pubis and with the Henle ligament just here. Laterally, we will see the lateral muscle with the most superficial. It is, of course, the external oblique muscle with the muscular part, and inferiorly, a very large aponeurosis part with some fibers on the psoas iliac muscle where we can find the femoral nerve. Here are the aponeurosis part, and we can find some pillar. The first pillar is the lateral pillar, just here, inserting on the pubic tubercle. Here is the medial pillar. Between these two pillars, we will find the inguinal ring. And here, the crust or posterior pillar described by Coles. Finally, we can find several aponeurotic fibers coming from the external oblique muscle and forming the anterior rectus sheath and the linea alba, and inferiorly the fundiform ligament of the penis. Finally, we can find this external oblique muscle, which is cut on this drawing just here. The skin with the penis, the scrotum, and the thigh. Between the pillars, internal, medial, and posterior, we can find the deep spermatic fascia. This deep spermatic fascia is coming from the transversalis fascia. And we can find some superficial fibers forming the superficial spermatic fascia. Here are some intercrural fibers described by Nicaise. Finally, here is the spermatic cord reaching the scrotum. We will draw the second drawing. It's the same drawing, but we will draw now the deep elements. The inguinal ligament is cut on this drawing to show its shape like a hammock, because behind this hammock, we can find the iliopubic tract of Thomson. This tract is made of transversalis fascia, of course. There is the rectus abdominis muscle, the tendon, and the Henle tendon just here. The vascular lacuna with the femoral artery, femoral vein, and the femoral channel interiorly, with the pectineal ligament or ligament of Cooper and the lacunar ligament or ligament of Jean-Bernard. Here is the posterior or pillar. Posterior pillar with the external oblique muscle, which is cut just here to see behind the internal oblique muscle. This internal oblique muscle has a large aponeurotic part medially, forming the conjoint tendon inferiorly and forming, of course, the deep inguinal ring. Laterally, we can find his muscular part inserting on the lateral half of the inguinal ligament, and behind the transversus abdominis muscle with its aponeurotic part and muscular part. The transition line between the muscular and aponeurotic part is, of course, the semilunar line. These muscles are cut, transversus abdominis, and here, internal oblique. Here we can find some transversalis fascia, and in the middle here, the Hasselback ligament, interfoveolar ligament or Hasselback ligament. This ligament is made of transversalis fascia and is followed by the epigastric vessels coming from the external iliac muscle. Medially, we can find the direct hernias or medial hernias, and laterally, the external hernias or indirect hernias. Of course, these two areas are limited by the epigastric vessels. Inferiorly, in the femoral channel, it is the femoral hernias. Here are the basis anatomy of these hernias. From the deep inguinal ring, we can find the spermatic cord. It is the deep spermatic fascia, and here the superficial spermatic fascia. And between these two fascia, we can find the cremasteric muscle coming from the internal oblique muscle. And note the nerves. The first nerve is the iliohypogastric, coming from L1 with its ends just here in front of the rectus muscle. Ilioinguinal with its branches, also coming from L1, and we can find here femoral branches, inguinal branches, pubic branches, and scrotum branches. The third is the genitofemoral nerve with this genital branch. Here is the femoral branch. We can find this last branch, genital branch, femoral branch. It is the genitofemoral nerve coming from L1, L2. Laterally is the lateral cutaneous nerve and the femoral nerve. So, one more time, iliohypogastric, ilioinguinal, genital branch of the genitofemoral nerve, femoral branch, the lateral cutaneous nerve, and the femoral nerve. We will now draw the posterior view. On this posterior view, we can find the posterior edge of the rectus abdominis muscle, the linea alba in the middle, the distal tendon with Henle tendon, linea alba just here, with the fundiform ligament of the linea alba inferiorly. Here is the level of the umbilicus. On this posterior view, we are drawing now the inguinal ligaments. With the iliopectineal ligament, laterally the muscular area with the psoas iliac muscle, with the fascia iliaca, femoral nerve, cutaneolateral nerve. Medially is the vascular lacuna with the external iliac artery, external iliac vein, and medially the femoral channel, of course. Here is the anterior and posterior rectus sheaths formed by the lateral muscle. The most posterior is the transversus abdominis muscle with this transition line. It is the linea semilunaris. There is the aponeurotic part of the transversus abdominis muscle, and here the muscular part of the transversus abdominis muscle forming the conjoint tendon inferiorly. This muscle is cut just here. And we are drawing this cut like this. Just in front, the second muscle is the internal oblique muscle, inserting laterally from the rectus muscle with the small aponeurotic part. And anteriorly is the external oblique muscle with a large aponeurotic part. And here is the muscular part of the external oblique muscle. On this drawing, the peritoneum is removed, and we can find some transversalis fascia structures in white. First, the iliopubic tract of Tenson, the deep inguinal ring forming the deep spermatic fascia, and here the Hasselback ligament, interfoveolar ligament of Hasselback. This interfoveolar ligament of Hasselback forms the linear arcuator of Douglas, the inferior edge of the posterior rectus sheath. Here are the epigastric vessels following the Hasselback ligament. The spermatic vessels are here, vein and artery, with the funicular artery coming from the epigastric vessels, and the vas deferens is here. The end of the vas deferens ends around the bladder. So we are drawing now the bladder with the urachus superiorly until the umbilicus, the uterus, and here is the vas deferens reaching the prostate and the seminal vesicles just here. The vas deferens is followed by the deferential artery, which is the third artery of the spermatic cord. Finally, we can draw now the obturator vessels, and this anastomosis between the obturator vessels and the external iliac vessels is the corona mortis vessels just here. They are just in front of the Cooper ligament and a high risk during the dissection. Here are the umbilical ligaments, and laterally the peritoneum, just here. The peritoneum is forming some ligaments. These ligaments are formed by three structures. And when the peritoneum is lifted by this structure, it forms some ligaments. In the middle, it is the medial umbilical ligament coming from the obliterated urachus, just laterally the median umbilical ligament coming from the obliterated umbilical artery, and laterally the lateral umbilical ligament formed by the epigastric vessels. Between the ligaments, we can see some fossa, the supravesical fossa, medial umbilical fossa, lateral umbilical fossa. In the lateral fossa, here the lateral hernia. In the medial fossa is the medial hernia and femoral hernias. All these hernias are here, and it is the view during laparoscopy with here the genitofemoral nerve. Finally, we can define in the laparoscopic view two triangles. Here is the triangle of doom with the risk of the vessels, and here the triangle of pain with the risk on the nerves. We will now perform an axial section following this line, passing through the deep inguinal ring. Here is this axial section with the anterior part and the lateral part. The rectus muscle, it is here the left rectus muscle and the right rectus muscle. This line is passing through the inguinal ring, so we can find laterally the transversus abdominis muscle and the internal oblique muscle just here. And then the external oblique aponeurosis just here. Some transversalis fascia structures with the Henle ligament and the transversalis fascia forming the deep spermatic fascia just here. And the transversalis fascia other side, forming the deep spermatic fascia of the spermatic cord. Here is the Hasselback ligament, and then we can see the lateral pillar of the deep inguinal ring. Here is the pyramidalis muscle. And then the medial pillar of the deep inguinal ring, control lateral medial pillar coming from other side, from the external oblique muscle, contralateral external oblique muscle. We can draw now the aponeurosis of the transversus abdominis muscle and the aponeurosis of the internal oblique muscle, forming just here the conjunct tendon that we can see other side of the vas deferens, forming here the crossed or posterior pillar of Colles. We can end the deep spermatic fascia, and here the superficial spermatic fascia coming from the external oblique muscle, and between the two spermatic fascia we can find the cremasteric muscle coming from the internal oblique muscle. Here is the penis with the urethra, and now the skin. The skin is here, forming the dartos muscle. It is a paucier muscle, dartos muscle, forming the scrotum. Now we can find the medial umbilical ligament formed by the obliterated urachus, obliterated umbilical artery, and then the epigastric artery. Laterally is the spermatic artery. From the epigastric artery, we can find the funicular artery. And finally, the vas deferens, right there. We can draw the testicle, and with the vas deferens, the deferential artery. Finally, we can find here the umbilical prevesical aponeurosis, and then the peritoneum, forming the medial umbilical ligament, the median umbilical ligament, and the lateral umbilical ligament. And from lateral parts, we can find the cloquet ligaments with the tunica vaginalis and the epididymis. Finally, here are the lateral hernia. Here are the medial hernia explained by this transversal or axial slice. Using this drawing, we can explain the position of the superficial repair. Liechtenstein repair is the mesh, and the preperitoneal repair here is the mesh. We will draw now to conclude two sagittal sections to explain the position of the mesh regarding the position of the nerves. On this sagittal view, it is here the iliopubic branch with the artery. It is a slice through the artery. The conjunct tendon is here with the transversus abdominis muscle, internal oblique muscle, external oblique muscle forming the inguinal ligament. And here is the transversalis fascia with the iliopubic tract just here, forming the gain of the vessels, fascia cribriformis, and here the peritoneum. It is the beginning of the spermatic cord with the cloquet ligaments, the spermatic artery, funicular artery, vas deferens, just here. The second drawing will be made through the Cooper ligament. So we can see here the Cooper ligament or pectineal ligament with the pectineal muscle just here. The conjunct tendon, transversus abdominis muscle, internal oblique muscle, external oblique muscle, inguinal ligament, transversalis fascia, iliopubic tract of Thomson, the cribriformis fascia, the deep spermatic fascia with all the elements of the spermatic cord, artery, vas deferens, pompiniform vein. Finally, the peritoneum is here, and we can explain the femoral hernia, direct hernia, and indirect hernia. There is the direct hernia, femoral hernia. Just here. This space is the Bogrov space, the peritoneal space is very, very important for the repair. So we can treat the hernia using open view. It is the Liechtenstein. The mesh is here, and this mesh is in front of all the nerves, ilioinguinal, iliohypogastric, genital branch of genitofemoral nerve. During laparoscopic repair, tap and tap, the mesh is here, and it is not the same nerves exactly like this. The last possibility is the tip, where the mesh is deep, but using an open way. So during Liechtenstein repair, the risks are on the iliohypogastric nerve, ilioinguinal nerve, and the genital branch of the genitofemoral nerve. During laparoscopic repair, tap and tap, the risks are on the femoral nerve, genitofemoral nerve, and lateral cutaneous nerve, exactly like this. It is necessary to know the territory, the sensitive territory of each nerve to understand the postoperative pain. In the middle of the thigh is the area of the femoral branch of genitofemoral nerve, laterally, lateral cutaneous nerve. On the scrotum is the genital branch of the genitofemoral nerve, and in the middle of the thigh, interiorly, it is the ilioinguinal nerve. Just here is the area of the femoral nerve, and medially, the area of the obturator nerve. It is not the same area, it is not the same semiology of postoperative pain after Liechtenstein and after laparoscopic repair. I hope these some drawings will help you to understand the repair.
Professor, I don't have words to express my thanks. Actually, it comes from the craftsman, and we are all sitting wonderstruck. We don't have words to express the gratitude. Professor Jignesh, you can take over.
Professor Yohann, I can just say that I'm seeing a Michelangelo or a Da Vinci or Claude Monet. You are just brilliant. You are absolutely brilliant. And I would say that a huge round of applause from you, from all of us. This is something fantastic and mind-blowing. I don't think we have a better anatomy explanation about the groin, the way you have explained today. Absolutely spellbound. And I'm extremely happy that I'm on board with you today. So just to kick off some questions, let me just be a little philosophical. So what drew your interest in anatomy to go to this level to understand it, and how did you go about learning this? I remember you talking to me in Manchester about your teachers, so I'll be happy if you can tell the audience that what is your lineage and who were your teachers, because the answer comes from there. Thank you.
Thank you so much for these very kind words. You know, I'm quite sure I'm not an artist, because it is only, you know, scientific and anatomical drawings. I learned that from my boss, of course. His name is Professor Avis. Professor Avis was the student of Jean Rive. Jean Rive is creating the Rives repair. When we say the Rives stopper repair, Jean Rives created my unit in France. Jean-Yves Repair is coming from Reims, from my unit. And one of his students was Professor Avis, and Professor Avis was my boss. And he taught me how to perform anatomy. And in France, you know, when you want to become a professor of anatomy, you must be able to draw the anatomy. So I learned during years and years. It took me around 15 years to know drawing the anatomy. And today I can draw all the anatomy of the body. I learned that it is very technical drawings, you know, it is not really artistic drawings. But thank you. I'm very happy that you enjoyed this drawing. And my question, I have one question, not for me, but for you. I don't know. I am sure that this way of anatomy, using the blackboard and the chalks, because using the chalk, we can draw on the previous drawing, and it is like three-dimension drawing. And in my side, I prefer such drawing, and I think many of my students like this drawing much more than three-dimension views. And I don't know what is your feeling about that. And I have a talk to perform about this topic in Austria next month. And I don't know what answer, because I like this way of anatomy, teaching anatomy and drawing one plane after the second plane and after the more superficial plane. I think it's much more interesting, and we can understand much more anatomy than three-dimensional reconstruction. I don't know what you think.
I think that's a brilliant thing, because my interest during my training days, we were sent in the cadaver lab, and it was very easy for me to then understand the operation well. And I used to refer to a lot of textbooks of anatomy, but I always liked the way you said that once you have one layer going off, then the second layer going off, it becomes easy to understand. In the 3D, once the model starts moving in all the directions, it's very difficult to orient yourself in the space that what exactly you're looking at. So I think the way forward is going to be the way you're saying, but I think we can have only one Johann in the world. We can't have many. Maybe I'll be very happy in the future if you can take up some kind of coaching, maybe something where you can have a classes and online classes and on-site classes, and we can reproduce, because I think 50 years from now or 100 years from now, this is going to be a history, and people should remember your illustrations, your drawings, and we should have the legacy going on. As you said, Professor Jean-Yves has started the legacy. You have continued it. So maybe it would be my
and the
request.
Education Foundation will be happy to associate with it and
Absolutely.
To popularize these drawings.
So we should probably have something in that form. My second question to you, Professor Yohann, is what is a way of teaching anatomy to the surgical students in France? Do you take all of them through some kind of anatomical cadaver lab, or we do this kind of illustration and then they see the surgery? So what is the pattern of training in your place?
Yes, that's a very good question. We had, I don't know, we had 3 years ago a new law in France, and we are now obliged to use a simulation. So simulators, cadavers, animals are necessary to teach anatomy. But, you know, the government didn't give us sufficient money to do all of this. So we choose in my university the cadaver. So during the sessions, I draw during introduction, whatever, I don't know, surgery, colon or peritoneum or hernias and so on. I draw the anatomy, and after, the students are going to the cadaver to perform the operations. And we try, but it's very difficult, you know. We try to make a progression during years for the student. Of course, this we use sometimes simulators, but they are very expensive. But we use simulators because we have not so much cadaver available for surgical training. But we try to do that. drawings, cadaver lesson, cadaver simulation, simulators, and after on the patient. We try to do that, not always easy. I don't know what is in India or other countries, but we try to do that.
So we really do not have a formal cadaver training in our surgical training, but we've been running some courses at my place, and we've been doing some courses in the abdominal wall reconstruction, which is going on pretty good with our cadaver model. And people are liking it now, and we are seeing more and more association with surgeons to come through. My next question, Dr. Yohann, is how important you feel is important to know all these anatomies of these ligaments before a surgeon embarks into performing a particular surgical procedure, like you rightly mentioned about the nerves. So how crucial, and apart from your illustrations, what are the other ways a surgeon should get used to seeing that anatomy and then start operating on the patients? Because as we always say, that nerve injury doesn't happen in laparoscopy, and you showed 5 nerves which can get potentially damaged in laparoscopy. So it is not only 2 but 5. So what is a message for a surgeon today in practice?
Yes, that's a very amazing question. Thank you so much. So, you know, in my opinion, the actual publication doesn't show what I will say, but I think it will come. During years, open surgery was performed for hernia repair. That explained that we had so much injuries of the superficial nerves. So ilioinguinal, iliohypogastric, and genital branch of the genitofemoral nerve. And we have so much patient with pain, neuropathic pain on these nerves. But now I see much and more patients with pain on the posterior nerves, because laparoscopic is performed much more. So I think what I have to advise to young surgeons is, when during open surgery, be careful to the fixation and the dissection of the inguinal folds, the conjunct tendon. The conjunct tendon should be shown, should be recognized, dissected, and on this folds on this conjunct tendon, we can see the 2 nerves, which are ilioinguinal and iliohypogastric. Second advice during open surgery is to be careful dissection on the spermatic cord. The ilioinguinal nerve is posterior and medial, and the genital branch of the genitofemoral nerve is posterior and lateral. So please never extensively dissect the posterior part of the vas deferens and the spermatic cord. That's the first way. Concerning the posterior dissection, tap and tap, I prefer tap because we can see very good the transversalis fascial layers. And the transversalis fascia is very, very difficult to teach and to understand this fascia. So there are many surgeons and many anatomists like me that are not are sometimes in opposition concerning this transversalis fascia. What is sure is that when you dissect the peritoneum, and you have to stay always just in front of this peritoneum, never dissect through the wall, never dissect this fatty tissue to the wall, because on this fatty tissue, there are 1 or 2 layers of transversalis fascia, and the nerves are here. Never dissect this fatty area laterally during tap and tap. And never, of course, never fixation on the lateral part of the groin area during laparoscopic dissection. I think these 3 advice are sufficient to avoid too much neuropathic pain after dissection.
So I think for the audience, I think you have, I'll address a question from this as well, but I think I would summarize and say that don't try to make the rectus abdominis bare when you're doing a TAP or TPP, right? Am I right? You should not try to make it bare. Let that fascia remain there. The posterior dissection, if you're taking the peritoneum backwards, just don't try to tease the tissue, because the more you're going to tease it, you will have a possible injury to the genitofemoral, and you may have a little bit of neuropraxia. And laterally, I always keep on saying that medial to the anterior superior iliac spine, your retroperitoneal nerves start entering into the groin. So one has to be extremely careful there. There was one question by Professor Bhatia, a senior consultant, because I recently...
Dr. Bhatia, actually, I started doing laparoscopic groin hernias by reading Dr. Bhatia's book. Dr. Praveen Bhatia is there. Actually, I am very much grateful to Dr. Praveen Bhatia for releasing that book. Actually, we could learn a lot of anatomy, especially inguinal anatomy, through that book. And Praveen Bhatia is there, Dr. Praveen Bhatia.
Can you switch on my video also?
Yeah, sure. You can.
Yeah. Thank you very much. Whom should I thank first? Dr. Beju or Dr. Jignesh or Dr. Yohann? Renard, you have done an excellent job. And honestly, I am amazed. You are a surgeon, you are an anatomist, or you are an artist. And it is 3 in 1 that you have beautifully demonstrated each and every layer. I am much impressed by the way you have drawn. And may I ask you that fascia transversalis is not much stress has been given. That is it a bilaminar layer or a trilaminar layer?
In fact, there's a recent publication, Johann, just to add on that, a Japanese article where they were saying 4 layers of fascia transversalis.
Exactly.
So I would need your opinion on that.
Oh, again, I don't know. What is sure is that I cannot answer with certitude your question. But in my opinion, I worked on transversalis fascia. I performed dissection and histologic section on each part of the abdomen, and it is very difficult to see any layer, even with histologic sections. So we cannot be sure about whatever. What we can be sure, for me, 2 things. First, it is quite sure that it is highly variable. And what we can find during dissection on a patient, perhaps we can find sometimes very good 2 layers. Once I see very good 3 layers, but I'm sure that it is very, very highly variable and difficult to generalize the problem. Second, I'm quite sure that there are 2 layers below the arcuate line of Douglas, because this arcuate line of Douglas is the end, the inferior end of the posterior rectus sheath. And I'm quite sure that this posterior rectus sheath is followed by a layer, which is probably the superficial layer of the transversalis fascia in the inferior part of the abdomen. And here, there are also the second layer of the transversalis fascia, which is the normal transversalis fascia that we can find around all the abdomen. So for me, but it's only a conviction, you know, 1 layer of transversalis fascia around all the abdomen and 2 layers on the groin areas. It's what I think, it's what I can see oftenly during dissection, and I'm quite sure is like this. But I think it's very interesting. But for young surgeon, I have to say again that during dissection, if you are just against the peritoneum, not opening the other layer, transversalis fascia and fat, if you are always against the peritoneum, quite sure that you won't have any pain after the surgery. what is my answer? I'm sorry.
I would say that beautifully answered. And I normally, whenever I am doing the workshops all over the country, I always say that you have to be connected to the connective tissues.
Exactly.
And I can see your passion coming out to be connected to the connective tissues. Thank you very much. God bless you. And we would love to have many Yohann rather than only one, as Jignesh has also pointed out.
Thank you so much.
God bless
Dr.
you.
Yohann, I have one question. When we are doing a TEP or a TAPP, sometimes we find that the peritoneum is absolutely forgiving. It's absolutely thin like a tissue paper. You're just worried holding it. And in some patients, it's absolutely well developed. So do you think it is the chronicity of the problem, or it is the way congenitally the peritoneum is made? Because the moment you see that papery thin peritoneum, you are always a little bit, even TAPP or a TEP, that whether you're going to close it, they're going to be buttonholes. So your opinion on the peritoneum?
Is again a very difficult question. I cannot swear to say that it is variable, okay, but I have to say more. The peritoneum, my boss always say the peritoneum is the dressing. I don't know if the word is good. The dressing of the abdominal cavity. If you have any problem in the abdominal cavity, the peritoneum will act as a dressing. So in case of inflammation, in case of bleeding, in case of, I don't know, any disorder, whatever, I don't know, sarcoidosis, Ehlers-Danlos disease, and so on. During all this problem inside the abdominal cavity, the peritoneum will change. And for me, it's the same in case of hernias. There is a small inflammation, and the peritoneum will act as a dressing, so it will inflate, grows for some patients, and some deflation and going very thin for some other patients. That is my answer. I think it is not only an anatomical variation, but a physiological variation due to the presence of hernia or other disease. And for me, probably explain that sometimes we can find very thin layer, and for posterior component separation, for example, for some people, it's very impossible because there is not sufficient peritoneum. And for some patients, the peritoneum is so high that we can perform any posterior component separation very easy, and it's the same for the groin area. That's probably part of the answer.
Yohann, we always say, Jignesh, can I say something?
Yes, sir. Yes, sir.
We always say that peritoneum is a single cell thick layer. And you have done so much of histological dissection, anatomical dissection. So do you still believe that peritoneum is a single cell thick layer?
I don't understand this word. Single
cell.
cell?
Yeah. Only one layer. It is a one layer
single
of peritoneum.
cell. I'm sorry, single cell. I don't know. I don't know because there is the fat area inside that, and during dissection and during histologic views, it's difficult to say anything because there is sometimes no cell seen on this layer, and we don't know if it is a single cell layer or only a fascia made of collagen and elastin. So for me, it is not a cell layer. It is probably fascia made by collagen and elastin, but I'm not sure. I'm sorry, I'm not sure.
Sure.
Thank you, Yohann. That was a wonderful explanation. And one thing which I liked about your bosses was peritoneum is a dressing for the abdominal organs. I think that's an absolutely a brilliant statement, and we will catch to it. There was one question which I can take probably very quickly is, do you have, with no disclaimers, any reference textbooks for surgical anatomy which a surgeon probably should refer? Because we have been using Scandalkis surgical anatomy quite often. So are there any books in France which are in French, but obviously they will have a lot of meaning? We can always get them revised with permissions and get them into English. So your recommendations? Because I
Yes.
remember you telling me in Manchester that you have referred to a lot of old textbooks from Professor Jean Reeves and, tried to gather all the information.
Yes. Yeah. I think the scandal is very good for the fascias, because Skandalakis was a very brilliant anatomist and surgeon about fascias, but it's very specialized. It's very difficult to understand. I think for very young surgeon, the netter. I think you have the netter. Yeah, the netter is
We have
very
the
good.
netter. Okay.
Yeah, the netter for me is very good. Is in all languages, and it's like my drawings, because you can see one posterior view, then the second view with other layer on side, and the superficial view. And I think the netter is very good for that. And we can see in the netter, in the biggest book of netter, cadaveric dissection to illustrate the drawing. So I think is one on the best books we can find for young surgeon. And after, I don't know, for specialized surgeon, particular for the groin, there are so much books. I love the Ben David one. I love the Fruchot one is wonderful, but it's very difficult to get. So for the groin hernia, there are so much books. I don't know which one to choose and to advise, but if you're very, very interested, do not hesitate to buy books, because I think it's very famous, and I love books. But for young surgeon, you have to begin with very simple anatomy, because I think groin anatomy is very difficult, and I always discover something during my dissection, because it's so difficult between all these layers, open anatomy, posterior anatomy, using the robot. We found new anatomy using the robot, because we are very in front of the structures, and I always discover something. So I think at the beginning, very simple books, and after more and more complicated book to know this anatomy. And I have to, yes, I have to admit that my trainees, the very young trainees, don't know very good this area, because it's very difficult to teach, and we have to be very concentrated on this anatomy to understand anything and to perform good repairs.
Thank you very much, Dr. Yohann. That was a brilliant. We've almost crossed 1 hour, and we have not realized because of this interactive sessions. On a lighter note, I would probably say that your kids must be, having scoring 10 on 10 in the drawing, because most of the times Yohann must be behind the scene and doing the drawings for their school. Yeah, is it the case? So
Yes.
I would leave it to Dr. Baiju to give the closing remarks, and all of you have been asking questions whether we will have this recording. So yes, this will be put it up onto the YouTube channel soon by Dr. Baiju, and we will have an access to this brilliant lecture by Professor Yohann. So thank you very much from my side. I am looking forward to see you in Delhi, where we will have an interacting session in the body lab, as well as we are all eagerly looking for your talk and your presence in India soon. So Dr. Baiju, for your closing remarks, thank you very much.
Actually, since this is an online platform, we are not able to give you a standing ovation.
Thank you so much.
Still, we are giving a standing ovation in the online platform. Thank you very much for this wonderful session. See, we are all even standing wonderstruck. It was an amazing session, and we would like to have more sessions like this on anatomy in future. And actually, as Jignesh was mentioning about having a long-time association with our Indian fraternity, please have in your mind that we can have such sessions in future also. So thank you so much. Thank you all the participants who are logged in from different parts of the world, different continents of the world. We are really amazed by the talk, by the drawings, by the by the anatomy, and this, with the permission of Professor Yohann, we will be putting in YouTube. He permits. Then any question from the delegates will be answered if there are any. And if there are no questions, we will be winding up now with the final conclusion from Professor Yohann.
So thank you again for your kind words, your kind invitation. I was very proud to be here, very happy to be here with you. I'm very impressed of all these participants. Hope everybody enjoyed, and hope to see you soon physically in, I don't know, other congresses. I hope to see you soon, and thank you again.
Thank you so much.
Have a nice day. Thank you, everyone. Thank you. Bye-bye.
Bye-bye.
Bye.
Hmm?